I'm very glad that we are having this discussion on this new technology, because I have always felt that new technologies are entering our medical space faster than we are able to really understand them or reflect on them or project the future, thinking about these technologies, sharing our opinions and looking at the social impact. And because of this, it could lead to unnecessary social harms and even disrepute to members of our medical fraternity. Now, in this particular case, with respect to social freezing of eggs, social freezing of ova for women, I think ever since the experimental tag has been lifted from this technology, there has been quite a bit of debate on this technology, especially abroad. I'm not sure about how many infertility clinics are doing this here separately, that is for social reasons and non-medical reasons. But I think we need to discuss and look at this more if we are talking about it in terms of women and empowerment of women. Now, a couple of years ago, the debate really hotted up when Facebook and Apple, these two companies, offered $20,000 payments or payouts for women in their companies who wanted to undergo freezing of their ova just because they wanted to postpone having a family. Now, this was, of course, it came into the media and there was a lot of discussion and so on. And really there were two sides of the argument about this. One is the company's stand on it, or the reasons why the company is doing this. Is the company really looking after the welfare of those women employees by offering them this facility? Are they really interested in the career of these women and their value and their future, their ability to pursue their dreams or their ambition? Or are they really looking at how they will benefit from having these women in the workforce? These are some things we could debate. Is it that they are providing a level playing field for men and women? Is there such a thing as really leveling the field for men and women? Or are they just denying the role of women as they are, or denying the essentialness of women as they present themselves in the workplace? As young people who have reproduction and fertility and sexuality as part of who they are, and peaks in their fertility as part of their normal being of being human and being a woman. So do these things need to be denied in order to pursue a career, or should they be integrated into the pursuit of a career? For years, it's been decades now since women have entered the workforce, and there have been calls from every side, institutions, NGOs, governments, calling for changes in the workplace that will integrate women more compassionately or more empathically into the workplace, affirming who they are as women, affirming their fertility, and affirming their role in society. Whether it means including facilities for women to have babies, have their pregnancies, and work, or adjusting work life to suit them, or whether it is compensation packages for women or facilities in the workplace. This has been ongoing, and it's incredible the amount of work that has gone into it and how little has been achieved. And now, if you have this facility available, paid for by the company, what does it do to the other women in the workplace then? Do they look at it as a pressure that they too will have to do this, even though they do not want to undergo any manipulation of their ovaries or their bodies for a non-medical reason? Will they feel the pressure that if they do not accept this package and postpone their babies, they will be looked upon as people who are not serious about their careers? Will they have that tag attached to them? So is there some kind of a denial of who they are as an integral person? And is our society indirectly, through these efforts in large companies, to nudge women to save their pregnancies for later, are they trying to create or really build this stereotype or endorse this stereotype of two kinds of women? One, a homemaker, and the other, a career woman. And clearly trying to draw the differences between these two, instead of trying to integrate the woman as a woman who can be a homemaker and a person in the workplace. So that is as far as the companies are concerned and how they will look at this, because it is a new technology and it is unclear whether insurance companies will really pay for this kind of elective treatment, self-treatment. It's like a choice of treatment. So, though insurance companies in some cases will pay for medical reasons to freeze eggs, it's not clear whether they will pay for social freezing. So what does it mean ultimately to the young person who is contemplating this? And what is our role as doctors and as advisors to young people who are thinking about social freezing? Is it only a question of individual autonomy and consent? Even in consent, for example, let's just take consent alone. What are we telling these young patients? Are we going to explain the entire process? Is the entire process being explained? Is the fact that it is an IVF procedure also explained to them? It's quite different. It's one thing to bank sperm and freeze sperm, but it's quite another thing, as we've just seen in the last 2 hours, to harvest and then freeze and then unfreeze a human egg. So is this being described to them in detail? Are their social views, are their own personal views being taken into account? What the cost of this technology and what it will mean to freeze an egg beyond a certain number of years. The success rate, it is very clear now that the success rate is much lower after the age of 35, 37 sometimes, but some studies have said 35 itself. The success rates drop. So what are we really offering them? Most young women, peak fertility between 25 and 35, and so they are unlikely to want to freeze their eggs during their peak fertility time, hoping they will be married, hoping there will be a change, hoping that they will get pregnant. And by the time they get post 35 and think, no, maybe I will not, or I need to freeze my eggs, it's already so late. It's already too late in some cases. So the risks, the unknowns, what about the unknowns, the ethical issues of sharing the fact that there are no long-term studies on this, and there are many unknown risks that could be there, as with any new technology. So this could be, during the consent taking itself, there could be misunderstandings and confusion created in the mind of young people when we use terms like preventive medicine and reproductive freedom. These are euphemisms that we have to be careful about. And as scientists and as medical people, we should not use lay terms which can be misunderstood. We are expected to be precise. We are expected not to use catchphrases, but instead to use simple technical terms with which to explain any new technology to our patients. And the ethics of the choice itself. Is there really a complete autonomy for our young people? Is there a complete autonomy for the individual woman in making this choice? It is, after all, the choice about a life, another life. So what about the rights of the child to be born out of this technology? And what about the spouse? The other persons in the life of that young person? And society in general. What about the views of society regarding the stages of life, the phases of life, the role of women and men in marriage and in families? What is the role of doctors in this area? Do we educate? Do we make aware? Or do we just promote every new technology that is received? What is the role of the government in understanding where the needs lie? Where is the need, the pressing need in the area of OBG health, obstetrics, gynecology, and reproductive health? Where are the big needs? Where should money be spent? Where should resource be allocated? These are important factors that have to be taken into account when looking at these new technologies. And also, whether insurance companies can cover it at all, and is that then viable? Will only one section of the population be able to afford it? In that case, what about the distributive justice part of the discussion? And the harms that come out of new technology should be expressed, not just the technology itself. Potential harms. It is possible for people to predict. It is possible for scientists to predict areas where there could be harm, whether it is harm to the child or social harm from class division and lack of access to technologies, or even harms to society as a whole when they perceive women differently, or they will indulge in exploitation of women where it is possible. Now here again, in freezing of eggs, if it is eggs that are below, for when eggs that should be used should be less than 35 years old. In that case, it will be donor eggs mostly that will be used. So again, women donors. Again, women who can be exploited for their eggs. An invasive procedure, an expensive procedure. And then, will a woman be coerced into undertaking this procedure because she will be paid for it? So again, exploitation of women in developing countries, exploitation of poorer women. And the views which come from segments or communities within society who anyway have reservations about in vitro fertilization, IVF and ART, those arguments are still there in the background. So for the arguments against about extra embryos, about use of extra embryos, disposal of extra embryos, use of extra eggs, disposal of extra eggs, these are moral and ethical issues that still are unsolved, and society is still concerned about them. So again, these are issues which will come up with this technology and which we have to take on board. And the general philosophical argument about this kind of a harmful artificiality to what is considered to be a natural process. And what do we do to ourselves as humans if we bring in manipulation and a sense of cold steel technology into what should be a human natural process? What does it do to us as humans, as a society? Will it affect the way we understand humanness or sexual inequality? Will it affect the way we think about the purpose of life, the purpose of human beings? And as doctors, are we expected to keep in mind the limits to medical technology? I think there's another ethical issue also brought up by Dr. Kale, and about the mismatch between the patient demand and the optimal outcome. And this is going to be something that has to be overcome before this technology can even be offered as a possibility for a social difference for women. A technology for women should not undermine who women are, and it should not exploit women. So if the ovum that is being used is from a donor, then one has to possibly look at whether that donor has been exploited in any way. And this will have to be, in a country like ours with very little regulation and oversight, it will fall to the doctor to see and protect these women. And then to look at the recipients. Is it just because we have infertility institutes that we have to promote these technologies? Should we promote it because the technology is there?
We are overshooting.
Thank you. I think I have completed most of what I have to say, and I'll be happy to take questions. Thank you.